or so, after which we'll have the question and answer session, the interaction, in which I'm sure Professor Carlos will be more than happy to answer any queries that you may have at the end of his lecture. So with these few words, I return it back to Dr. Arjun.
Thank you, Professor Dr. Krishna Nayak. I now request our speaker for today to kindly come forward and deliver his lecture. Over to you, Dr. Carlos.
Okay. Perfect, and the slide is there. Thanks a lot again for the invitation, and I think it's been a long day for some of you, and so I appreciate staying so late. And happy Father's Day for the ones that are fathers, and obviously we all have fathers. Thanks a lot. So this is quite an important, interesting topic, but quite a broad topic. So I am going to basically focus on the presentation about the discussion of the relapse retention from the dental point of view, although I know it's quite important also the craniofacial growth and how that it may or may not impact. So in other words, there's the concept of relapse retention from the point of view of maintaining the final dental position, as there is a potential for discussion about the stability of the craniofacial growth and the changes long-term of the face. So I guess follow that, and I guess I would appreciate not to get recording because there's some patients' photos in the presentation. And it's important to acknowledge, and I know that India has been hit quite hard over the last couple months, right? And then we're lucky in Canada, it seems that we are coming out of it. So there's light at the end of the tunnel, but I think that it's important to reflect that the pandemic has a lot of negative effects, but some positive effects, and I think that it has made us realize that the potential of webinars and distant lecture, right, and being able to share knowledge through distance and this situation. But again, in the middle of difficulty always lies the opportunity, right, to do something and learn something from the process. So I will start with a very important recent paper published by my friend Daniela Garib from Brazil, Bauru, just to understand what we should expect is going to happen. In between, we finish an adolescent patient, and then if we were to follow those patients for 40, 50 years, what will happen? What is the interaction between normal craniofacial growth, equilibrium between muscles, the tongue, the cheeks, the lips, and the stability of teeth? I am going to focus then on the use of a relatively new, although it's 5 years old, Cochrane review on the concept of orthodontic retention, because they actually make a very interesting analysis of a comparison between fixed, removable options, fixed options, the use of IPR, adjunctive orthodontic procedures like positioners. And I'm going to try to use only the Forest Plus to facilitate the conversation, and they're going to be part of the presentations, which I am going to be changing their analysis, maxilla, mandible, intermolar distances, intercanine distances. But it's just to give us an idea about what we really know and what we really don't know so far. So let's start with normal craniofacial changes into adulthood. Now, do we think that we know, we can predict what's going to happen, right? Is this going to be just a nice, open, clear sky day? Well, in reality, it's a journey into the unknown, right? And I say unknown because, and we're going to see some slides at the end, I think that the more we read about the topic, the more we will realize how little we know. And especially those that are younger, right? So we think we know a lot when we were younger, but then life and experience tells us how little we know. And so, and as an academician, my presentations are usually a combination of cases, clinical concepts, but also literature, because I believe that it's important to understand what we know from the point of view of what's been published, which is not always necessarily a reflection of real life, but it's what we have. And so basically, I am a fan of Game of Thrones, right? And I found this quote quite useful for the topic we're covering, right? A reader lives 1,000 lives before he dies, or I guess an orthodontist that reads probably is going through the life of 1,000 orthodontists that did treat patients and made mistakes and convey to us their knowledge. right? While the one that does not read anything probably lives only one life, its own life, as good and useful as it is. So this is for me a very important paper, right? And this is just was published 3 years ago, it will be 2.5 years ago, right? And from the University of Sao Paulo, in Bauru. And basically, it's a very interesting paper. Why? Because they actually follow up. Again, these long-term studies are difficult to have large samples, and so again, we can go over 22 patients. How much 22 patients are a reflection of more than 6 billion of persons that live in the world, right? And that's a fair criticism. But anyway, nevertheless, it's a very good paper considering what we have now. What's important to understand, and these are untreated individuals, right? They were not orthodontically treated, and so they wanted to basically compare patients that when they were teenagers, 13 to 17 years of age, they decide not to get treated, or for different reasons, right? And in Brazilian universities, federal universities, actually treatment is provided at no cost for the individuals. So money may not have been really, it's just they decided that they didn't have a malocclusion that will warrant treatment. And so, retrospectively, this group of researchers did contact this sample of individuals in the late 50s that had records and were not treated, and tried to track them down through the country, and only could reach to 22 of them, right? And then they took records of these individuals around 40 years later. And so what we're going to see here again is not relapse from the point of view of orthodontic relapse. This is basically changes that will happen in untreated populations. And my understanding is this is the the longest time period that an untreated sample has been reported, right? And you see here that the records these patients were seen between 1967 and 1974. And then after the process of identifying them, we have a final sample of 22 subjects, which by the way is 27% of the initial sample. So what we have here now is, and I will probably focus on the images, it's easier more than the figure itself, right? These are 6 of the 22 subjects. And you will see here time 1, 1967, and then the follow-up through the years until 40 years later. And so just look into every case, and you're going to realize how this patient or individual, was never a patient, orthodontic patient, had a little bit of crowding. And then you see how through time that crowding increases. Probably not to a point that treatment is necessarily something that everybody will go through. You have, in case B, a better, you would argue, a better alignment, but then actually the amount of crowding, it's more compared to this one. And so far and so on, you see cases with significant crowding at start, they stay significant crowding. So the message from here is there is not necessarily a consistent pattern. In other words, cases that were better at start developed more crowding than cases that had mild crowding at the end, and cases with a lot of crowding didn't get more crowding. So message again is that this crowding or relapse or not for treatment actually increases, but doesn't increase in a linear way. It actually increases based on individual factors that we don't know, based on the limitations of following patients 22 years later. And then we could also then assess this series of changes from the point of view of the deep bite or the vertical bite, anterior bite. I'm going to see then in this group of patients, right, the same 6 patients, and then we can see how in the first case, interesting enough, the bite did open, right? And then in the last case, the bite did open, but in this case, the bite did not change. In this case, the bite did open, and in this case, the bite did open. So 4 of the 5 cases, the bite did open with time. In only 1 case, then the bite did, I will say, stay the same. So think about it. So deep bite cases are, based on this small sample, are going to likely get some degree of improvement over the next 40, 50 years of age. And I think that the amount of improvement here is a little more consistent than the amount of rotations that we saw in the previous slide. So the conclusion of this paper, and my analysis of the paper at least, right, is that I classify the changes into three groups: increase, decrease, and no changes. Again, remember 22 patients, individuals, right? No well treated. And so the things that do increase with age, over 40 years, are clinical crown height, which is probably a reflection of recession or, I guess, movement of the gingival tissue away from the occlusion, increase of mandibular crowding, and increase of palatal depth, right? Which is a one tricky to explain based on the records they took, right? But in other words, two options is basically a constriction or a dental lingualization of the upper teeth with the dental bone, right? Or simply a reflection of vertical growth, which is now linked to that open bite, and basically just makes the palatal deeper. The factors, variables that do decrease are the mandibular, intercanine, interpremolar, and intermolar widths. I tend to use the MD for the mandible and the MX for the maxilla. Sorry for my abbreviations, but I'm trying to get the slides as clean as possible, right? There is also a decrease in perimeter, so that explains then in the lower arch clearly the tendency for more crowding, tertiary crowding, we can call it, right? And they were able to quantify wear in between the interproximal contacts, not IPR, and through time, therefore, that tooth size discrepancy decreases, my mistake. And finally, in regards to no changes, we have overjet and the maxilla, intercanine, interpremolar, and intermolar width. So I hope that these slides will then summarize and opens your eyes about the perspective about the long-term changes, untreated cases. And so this is not about the type of retention, it's simply what's going to happen. So lifelong retention becomes a must based on this paper, if patients want to maintain their results, right? And so what we should do then, thinking about this in our treatments, right, as an overall statement, right, is when should we overcompensate in our treatments? And so I guess it will be the reverse of my previous slide. So we should not increase clinical crown height. And I don't know how it's in India, but here we're getting more and more exposed to the concept of laser surgery, gingival laser surgery, as a way to increase the clinical crown and get this beautiful smile in a 15, 16-year-old. But I'm not sure, I would like to see how that clinical crown height is going to look when the patient is 30, 40 years older. So anyway, probably, and again, just a comment, do not increase clinical crown height. If you have some mandibular spaces, maybe you don't want to finish with those little spaces there, because those spaces could actually be useful to avoid those side effects of the lamp. And then I guess do not increase the palatal depth. What you should consider to increase is, I guess, the mandibular dimensions, and this is going to be controversial, probably part of our conversation after the presentation. What do you mean with increase, right? Because if you increase the chances of relapse. But I guess if you were to increase a little bit of the mandibular dental dimensions, then I guess you overcome some of the expected relapse. Certainly increase the overbite. I guess it goes back into 40 years later, right? So then adding a little overbite would not be a problem. Perimeter, and then I guess concept of do not IPR. I'm going to talk about IPR thereafter, right? And then maybe your end should be based on overjet and maxillary dimensions. Anyway, one interpretation of this important paper. So let's go now over one case, and this case is just a reflection of how fascinating is nature from the point of view of if you change the environment, what could happen. And again, these cases are simply a sample of one. So I'm not trying to imply that this is going to work all the time. And so what we have here is a patient, 9-year, 4-month-old patient that it's referred by the dentist because of upper left first molar that was not erupting. 9-year-old, you will argue that this is not a delay eruption from that point of view. Certainly there's a factor there. An analysis of the pan doesn't reveal anything, but I guess the assumption were after an analysis, a tricky diagnosis, ankylosis of the first upper left molar. The surgeon went in and subluxated that upper first left molar with expectation to see if after luxation that molar will erupt. Did not happen, right? And so I guess the point is that it's likely ankylose again. Bottom line, decision made to extract the molar because over long term having a partially erupted first molar will not help several aspects. And now it becomes more or less a journey to observe what will happen with the second molar, second left, second molar, right? And you see here that then a year and a half later, you start seeing how this second molar is starting to erupt into the extraction space of the third molar, and we are probably in 50% of the space now. And then time goes on, and a year later, now you see, well, voila, the second molar did actually fully erupt in the space of the first molar. And actually by itself, no orthodontic treatment, right? Obviously, and I'm not sure how easy it's going to be seen on the screen, we have some side effects of that, and it's an over-eruption of the teeth in the posterior here and over-eruption of the first molar. So, but these are not things I'm dealing at that moment. I'll probably try to deal that with them later. Around 2 years later, patients 13, and probably around 12 years and a half to 13 years, we started with orthodontic treatment, and now with the expectation to align and level the dental arches. And now I will ask you to then now start monitoring the upper left third molar and try to see if by default it could actually come in the space of the second molar, which will be an ideal scenario. And as we move forward then through time, we finish the orthodontic treatment, right? And then you see a relatively adequate occlusive result. And then this is the second molar in the place of the first molar, and this is the third molar, and then a year's this will be stability. But stability is an interesting concept when you realize that we have a braided retainer in the lower arch, right? So how much is stable because I have a fixed retainer and not necessarily because of my treatment was stable per se. And then we're going to see then how the third molar keeps erupting, and ideally will erupt there. And then something that I guess could be questioned in the end result is an over-eruption of the second molar. And so that was something that probably I failed to foresee. I was so focused on the upper first molar. And you see a little step here. And and then this will be then the end because this is 2016, and then I'm just monitoring how the second molar is erupting. So the Cochrane, and again, that is, I will try to really go over the next 30 minutes over this paper and in specific detail because of the way they present the data, right? And then I am not, one of the things that, because of time, this has been 5 years of research after that, and there's been a few papers about retention, type of retentions over the last 2-3 years, and a few RCTs, which is great. But the point is, I've been monitoring the topic, and I don't think that's conceptually a significant change in between what this Cochrane review concluded in 2016 and what we know today, right? And for the purposes of the didactic of the presentation, I decided to focus on the Cochrane and the way they present information. So we're going to start then with the idea about the overall, what did the Cochrane identify by 2016? And they identified 13 randomized control trials, RCTs, right, and children and adults, in which orthodontic retention devices were used, right? We may or may not like it, the way they quantify relapse, dental relapse, was with the use of the little irregularity index, right? And again, that's what they use, and we will just report that way. And the meta-analysis were done only when there was acceptable or adequate clinical and methodological homogeneity. So in general terms, right, I will tell you the end of the story and then I'll tell the details. Well, the level of certainty, certain level that is something I really emphasize nowadays compared to years ago, which is how certain are we about what I'm going to tell you, the story I'm going to tell you. Well, for rotations or the prevention of rotations, the certainty of the evidence is low, which basically means that new papers coming actually could change this in a significant way, okay? For the other objectives, outcomes, variables, the certainty was very low, which is the lowest possible certainty level, right? And this is used based on the wording of the grade assessment tool. And then failures, breakage, again, do exist. Secondary effects do exist. And the satisfaction of the patient with the retainers, we're going to talk important topic later, then the level is low. And then this is a little bit of what we face with these RCTs, which is a good number of red dots, which implies that the evidence we have, although coming from RCTs, is not conclusive. It's some, it's good to have the evidence, but it's not to be categorical in the conclusions. I am not going to spend too much time in methods. I'm happy to talk about methods, but I know that what we want is to go as a clinician to, let's go into information I can use in practice. But I want to be sure that we have an idea about the background information, and I will leave it there and just go into what I report. So things they are considering this Cochrane review is in regards to removal retention, the use of the Holly, thermoplastic, and Beck retainers. In regards to fixed retention, the use of twisted wires, fiber-reinforced plastics, and positioners. You could argue, actually, as a way they classify, I would say positioners is probably not a fixed retention, to be removable, but I'm just reporting the way they present information. And we're going to have a chance to talk about IPR and periodontal approaches after finishing our quantity treatment. So let's start first. And there's going to be 5 main questions. This is number 1 and the one that they have more data, which is the conversation between the use of fixed and remote retention. So think about yourself in practice. And this is trying to give you some idea, should I use fixed? Should I use removable? Is there really evidence that one is better than the other one? And if there was categorical evidence about that, I think that we will expect that all of us will be using what is categorically better. So I guess there's no surprise that I'm not going to give you full clarity, right? And that's the reality of clinical practice. It's a lot of opinions and then a little science of it for the opinions, right? And they did focus on this conversation between removal and fixes on the lower arch, right? Because that's really where you make up go 50-50. While in the upper, most will go to removal and a small proportion into the fact of using a fixed retainer in the upper arch, and we can talk about that. One study compared Holly versus fixed, and the study number 2 and 3 will compare the thermoplastic, not the Holly, against the twist. Anyway, so this is a little bit of the typical slide I'm going to be showing quite a lot. Not that I want to spend too much time per slide, but just want to explain the slide so that you have an idea what's coming from. So what we have here in the upper left and right corner is the type of retainer they're comparing. Sometimes visually it's easier for us, so they're comparing basically here you see thermoplastic against fixed retainer, 3-2-1, 1-3, right? And then basically what they figure out after 1 year, and this is a little bit of this one paper, one RCT, 4 greens, 1 red, 1 yellow. So I guess you will argue reasonable evidence, not strong evidence. But the point here in these slides is basically to focus into overall in regards to alignment, the twist flex compared to the thermoplastic, lower arch, anterior segment, seem to be the winner. And I say winner with a caveat. And that is that the difference in between using a twist flex or a thermoplastic is a reduction of the little irregularity index of 0.6 millimeters. So if you want to call it a winner, we should be using the twist flex and not the thermoplastic in the lower arch. But think about that, 0.6 millimeters. So maybe there are other factors we're going to be talking about that are more important than the 0.6 millimeters. And so as we move forward, then what we have here is failure defined as breakage of the device, right? And so I guess from that point of view, the twist flex, right, I guess, breaks less than the thermoplastic, and I don't think there's a surprise there. So it's a reduction of chances of the breakage by 2/3, which is a lot, right? But understand that the twist flex, the failure of these could be the bond, not breakage, right? And that still implies for us to go to practice and then just clean and rebond, and it takes time and money. So in the big picture, and again, that we can talk about that, cost of replacing a thermoplastic is lower. I will argue that over 5 years, been rebonding the 1 or 2 spots of the fixed retainer. They both do not facilitate caries, so caries doesn't seem to be a problem in between fix and removal. But then from the gingival point of view, right, no surprises, we will expect worst, and again, that's a strong word, but the gingival health will be worst with the twin flex compared to the thermoplastic. And that's more than 50% more. And again, no surprises, but the question becomes into gingival bleeding and how that reflects what? Is that periodontal disease? And from the point of view of the definition, it is, but is that significant periodontal disease? I guess also how you handle that, then I guess it's, well, be careful with the twist flex and then the explanation of oral hygiene and the follow-up of that, or with the thermoplastic, simply give that to the patient and then not necessarily a discussion about oral hygiene. All of these studies are 1 year follow-up, which is a short term there, right? And then we go from gingivitis or bleeding, and then again, well, now get into a problem, and this is not periodontal pockets, right? And so certainly the twist flex will be more likely to produce periodontal pockets than the thermoplastic. And so far, I guess the point is which one you prefer. The twist flex is giving you the more stability or lack of relapse, things stay where they are. But the downside is that your periodontal conditions are going to be worse. And so it's the 0.6 millimeters that you may have to accept in regards to potential relapse, but then healthy periodontal tissue. And I think each one of us has to make that call or discuss that information with our patients, right? Now, from the point of view of the patients, which is quite important and interesting, well, patients will prefer twist flex than the thermoplastic. And that is likely going to be related to the fact that it doesn't require the patients to remember about the retainers. But that's exactly why then it becomes an issue with the gingivitis, bleeding, and periodontal pockets. So just because the patients like it doesn't necessarily mean that's the way to go. And so we go into another way to measure, quantify satisfaction, and that will be the use of the concept of being able to clean, not what you observe as a gingival response, but the patient's perception of the cleaning. And then actually, interesting enough, the patients feel like cleaning the twist flex is easier than cleaning a thermoplastic. I'm not sure I agree, but that's what the research is reporting, right? And that's a patient's experience, which is something that we need to take into account. In regards to appearance of the teeth, remember the 0.6 millimeters? Well, I guess for this RCT, when the patients were analyzed, the patients did not find a difference in the alignment in between both. So the 0.6 was not something that they care or would consider a problem, a failure. So we wrap up that conversation about fix and removal. And as we can summarize that, then the fix that is being contrasted is a twist flex. So it's not the bar, it's not the 3-3 bar. So can we extrapolate that to that type of retention? I'm not sure we can. And it's the use of thermoplastic, not the Holly. And again, thermoplastic, Holly, there are differences there. So just to kind of make, remember that this is not necessarily a significant external validity, simply the comparison with twist flex and thermoplastic, which are the most common options, which is good. So another case, now this one here is actually, I use it sometimes when I talk about impacted canines because there is going to be a canine impaction. But the arch I want you to focus is the lower arch. The reason for that is look carefully into that pan at the left side of your screen, right side of you. And we have missing teeth in the lower arch. And actually, we are missing 2 incisors. I made the assumption that the missing incisors are the centrals because of basic theory, but I guess it becomes into measuring or not. But they're 2, which is highly unlikely, but happened with this patient, right? And so let's observe what happened with that lower arch that I'm not going to treat. And so a sequence of pans over the years. And then now look in between 3 years, March 2008 and January 2011, look what happened in the lower arch from the panoramic point of view. And again, I did not treat the arch. And then year later, we have a lower arch looking the pan not perfectly aligned. There's not necessarily root parallelism, but it's looking good. Now I'm going to show you the clinical picture, and I want then you to look into when I start the treatment, but then think about that patient initially, and then now look at that lower arch. That lower arch now has no treatment, but then the baby, the lower left deciduous canine, good 73, is still in the mouth. So nature did accommodate the teeth in a wise way. And so now I'm facing, I guess you could argue, a one missing incisor scenario. But it is what it is, right? And part of the conversation is going to be about should I have treated that arch or not. And so you see it's 16 months of upper fixed appliances, reasonable occlusion, some gingivitis and hyperplastic gingival tissue immediately after removing appliances, especially around the tooth 1.5 and 2.5. And then the central has this fracture in the incisor border that the patient decided not to treat, manage at that time. It's been years since I've seen this patient, right? But then look at the lower arch, and I didn't treat the lower arch. And this is 5 years of follow-up, not treatment, and then the before and after, and look at the lower arch the moment I saw the patient for the first time, and look at the lower arch after 5 years, just nature doing the job. So now, probably for the topic of today, this becomes then an important point of conversation, right? Is this a perfectly aligned lower arch? No, it is not. Could I align that arch? Yes, I could. Would have been a significant amount of effort to align the lower arch? No, not really. But think about it, how simple, easy will have to be to align those 2 lower incisors. You could do that now even with plastics, right? Clear aligners. Not a significant effort, but this is what nature got me, this patient. It's stable. I guess it's stable at the moment I took the X-ray. The photo. Why would I like to move that when the patient doesn't care? That lower. Why to treat the lower? I don't need a retainer. But now, if I want to see this patient 40 years later, you saw that paper I showed you earlier, right? So probably this is not going to look the same. So stability, long term. I guess I don't regret my decision not to treat the lower arch. What I'm saying is that if I were to call this patient back, in Canada there's a lot of movement. Kids do finish the high school and then they move to other country to continue their studies or work. I would assume that's the same from India, and so then following these patients over long term is not an easy task. Okay? So is that successful? In my definition, and that's going to be one of my last slides, that's successful for me not to treat and actually let nature do the job. So we go now to the comparison between fixed and fixed. Okay? And then upper and lower, 2 papers each, right? And then I don't want to spend too much time per slide. I'm just going to get back into the conversation at the end of the session, right? I can tell you that in this summary slide about failure rates, right? And this is fixed and fixed, but I guess it's fixed and fixed, and the explanation is in the different columns there between a 3-3 and a twist flex, so just a flat wire or a twist flex in the first row, and then the second is going to be a plain and a twist flex, a thin twist flex. Anyway, a lot of different things, but in conclusion, in this slide, there were no differences between arches and upper and lower. So in other words, the reality is from the point of view of breakage and failures, it doesn't matter if you use a twist flex or a flat wire, right? The problem is these RCTs that were included did not assess necessarily stability, side effects, and patient satisfaction. And the follow-up was not clear. Now, so sorry, not a lot of clarity, but it seems that based on that either fix works the same, from good or bad. When they actually compare now removable versus removable, so basically back thermoplastic, variations of thermoplastic, or time of use of thermoplastic, that's kind of an important point to talk now. What we identify here is that if you were to then talk about stability, and important here becomes about the usage, right? We're not comparing, this is Holly against Holly, but then the situation with this is that when we go into this use of the removable, right? And then they are comparing that only nights for a year versus asking the patient to use the removable, the Holly, all day for 6 months, and then only nights for another 6 months. It does not matter. So I guess the point is, then you go into Holly all day for 3 months, and then half a day for 9 months, or a thermoplastic S6 type, half a day 1 week, and only nights 12 months. It does not matter. Thermoplastic 8 hours 12 months, or all day 12 months, it does not matter. So when I said it doesn't matter from my point of view, but then for one of them, and that will be for the whole liver to the thermoplastic, there was a 0.25 millimeter relapse with the Holly. Is that clinically relevant? I would argue not. But the point probably from this slide, from a point of view, is more that 0.25 relapse is, I still, and I guess that should not, is this concept of the need to get the patient to use the removable retainer all day for the next 6 months. And the evidence is not there. So as long as the patient uses that retainer half a day, 8 hours while asleep, it seems that the stability or lack of it is the same. And the patient will appreciate if you tell them to use a lot less than we actually ask them to use it, right? I think we ask for the moon, expecting that the patient's not going to use the 24 hours, and they use actually 8. And so I guess as a clinician, probably our concern is you need to use 8 hours is fine. They only use 3. So I think that's probably around that area what clinicians recommend more use than time use that they actually need to, right? And so maxilla and mandible, where they compare, and again, only nights, all day, 6 hours, it's no difference, maxilla and mandible, right? When they focus on the intercanine in the mandible, intercanine distance, which we realized from the first paper that actually something that is going to be reduced with time, well, I guess at that point of the analysis, there was no difference, right? And so in other words, there's a 1 year stability regardless of the type of removal retainer and the frequency of use. The same for the intermolar width, and the same will be for the overjet. Thermoplastic all day, 8 hours a day. No difference for overbite. And now careful here, right, is because that's where we have some, and this is going to focus on posterior occlusal contacts. Well, in this case, they are comparing a thermoplastic that's modified, right? And then compared to a standard and the use of all day for 6 months. And the second comparison there is 3 months, 6 months. So what they concluded was that there were no differences in contacts with the full-time use over 6 months. There is an increase in contacts by part-time use by 3 months. So as a clinician, this is a very important slide because again, I am not sure how good you are in finishing all your cases with solid contacts. But I guess in those cases in which you the patient could use a little bit of improvement in the contacts. One way to handle that is don't ask them to use the full coverage plastic retainer full time, because obviously it's not going to allow any settling. And so an option you have then is to simply allow then the use of part-time use, half a day, for 3 months, and you're going to see an improvement in occlusal contacts. And so if we go back to, or summarize so far, what we understand is the fixed retainers they appear to be better in maintaining a position of teeth. But then, I guess if you want a little bit of settling, maybe you don't want to use that fixed retainer, you want to use a removal retainer, because the removal retainer is going to allow you to some increase in the occlusal contacts, right? When they look into the anterior contacts, exactly the same, right? And so, this is not fixed against removable, it's removable, use different hours, but if you want to improve contacts, reduce the number of hours of use of the and the changes are going to be minimal, but then useful for the patient. In between the Holy and the thermoplastic, well, the thermoplastic clearly wins. In other words, the thermoplastic it's more likely to maintain teeth position than the Holy. Now, the situation with the Holy is that it's a little unfair comparison, because with the Holy, it depends a lot on how it is done, lab technician skills, how the clinician actually adjusts, right? And so from that point of view, I guess be careful with this one, but the thermoplastic cannot be changed, but it's, from that point of view, clinically significantly more stable for the teeth position than the Holy. But we decided to use the Holy something for allowing some degree of eruption of posterior teeth. So that's more clinical practice decision, right? Right, and this is the par, and then we're going to see over this that, well, I guess from the point of view, the back then is not necessarily as good in this case compared to a thermoplastic, because then it allows the increase of the little irregularity index. Okay. Now, in between the thermoplastic and the Holy, then the Holy is three more times more likely to break than the thermoplastic, which is interesting. I don't feel like that's happening in practice. I think it's reversed, but I'm just reporting what these papers are saying. Okay. In regards to losing the retainers, then I guess you get a similar frequency of, I guess, losing a Holy or thermoplastic in the big scheme of things. They should be similar, right? You either put in a wrong place and then napkin, and then you forget about it. The prevalence of failures, and this is not to lose it, but breakage, then the thermoplastic is more likely to fail. From what point of view of breaking, right? You use and the plastic eventually will wear down and stressed and break. And then we know that with thermoplastic, we will have to, with the patients every 18 months to 24 months, we will have to get a new one. While the Holies, they seem to be last way longer. Quenching, it's likely going to be affecting that long-term wear of the thermoplastic, because they actually cover the teeth, and by the crucial coverage they protect the teeth, but they are getting worn down, where the Holy will not protect the crucial surface of the teeth, right? And getting to the end of this section of removable, interesting enough, the Holy is a lot more likely, or one more time more likely to be used than the thermoplastic. Interesting, because we expect patients patients prefer the clear retainer, the thermoplastic, but that's not that they will use it more. This data basically suggests that they're more likely to use the Holy than the thermoplastic. Interesting. I don't see that in practice, but that's what's reported, right? Is that difference clinically relevant? Right. And then the actual, and this is an important slide, actually used at home is relatively similar, but that's a number you need to understand, right? And so when we ask patients to use the remote retainers 24 hours a day, except 323, except eating and brushing, the reality is your patients are going to be using that around 70% of the time, right? And so it's a conversation about when you ask for full-time, you expect part-time. And so you know that part-time is going to be enough. That's a little bit of another conclusion so far, right? And then patients showing the retainer or actually actively closing the lips and not smiling because of the retainer, right? And then I guess obviously then the patients with the thermoplastics are more likely to be able to smile compared to those using the Holly, right? Satisfaction is quite high between both, near to 90%, right? So patients are happy with these remote retainers in the big picture. Okay, and now when they twist the question and ask about between the use the removable against fixed, right? Interesting enough, patients would prefer a fix in the back because of aesthetics compared to the Holly. The problem with the Holly is always that significant piece of bar in the front teeth, right? But again, that is a relatively number of people. There's a difference there, a significant number, but there's a difference in between. Okay, so we wrap up this conversation about the removable versus removal, right? We are around half of the middle of the presentation. And I'm going to show you another case, and now it's just to open the conversation about craniofacial growth. Not necessarily the concept of relapse from the point of view of dentition, but more about craniofacial growth. A patient that is an immigrant, immigrating to Canada as a refugee from a war zone, already with orthodontic appliances, and already with extraction of premolars. The point is, I guess I had to simply then treat the case with extractions already, make a decision, right? And then there's a fixed retainer and reasonable occlusion, right? And so the point of this case is going to be not so much if the teeth to shift, but look at the face and how the face is going to change. And you see that this is a convex patient, convex profile with a vertical growth. You can see that from the upper left lateral view. And so 14 years and 6 months, so male, still growing. And I guess you see it's almost 5 years later, retention, 57 months. And then what we observe now is not necessarily a problem with alignment. Lower alignment is still the same. The upper, you see the laterals have rotated slightly initially. But then, some patients not really been using now the remote retainer anymore, right? But then the changes and the lack of success of the occlusion is not probably regarding intra-arch characteristics. This is basically because the patient keeps growing. And so again, when we talk about orthodontic retention, we may want to talk a little bit about retention from the point of view of avoiding overcome craniofacial growth itself, not necessarily the retention of the dentition. We go now into the area of the sorry about the typo there, mandible versus IPR. In other words, if I do IPR and then flatten the contact points, do I need to then still use a fixed retainer? Right? And so, well, I guess it doesn't matter. They're both equivalent, so think about it. So maybe by doing IPR, you avoid the use of the fixed retainer, and then you avoid the problem with the gingivitis and the periodontal pockets, or the potential periodontal pockets, right? And then in use of aligners, sometimes there's a good number of people, clinicians using IPR, and maybe by using the IPR, then that will be enough. Again, interesting concept, only one paper, actually, really, really good paper from Turkey, all green, as you see in the top. And then when they follow up that about the intercol canine width, no differences. At 1 year, by the way, intermolar width, no differences. Perimeter length, obviously, no differences, right? And so, again, part of this is because, and I need to clarify because I think I misquote myself, is that if you look into my notes in green, and sorry about that, I realize I misquote myself, it's IPR plus the mandibular, so in other words, the thermoplastic because that. So the retainer there is in the upper, but it doesn't seem that they use a retainer in the lower, in this one of the groups, and that's when my comment about the IPR comes in place, right? No difference in anterior irregularity in the mandible. And then there were some differences in the mandibular intercanine width. And again, that's expected based on that first paper. 1 millimeter reduction after 1 year in the IPR group, and then 0.8 reduction after 2 years. In other words, it's a cumulative 1 and then 0.8. So there is some relapse there, right? And I think we know we have clarity about that, right? And so the canines are going to move lingually without a retention. And then we go near the end of this part of the presentation when they look at the maxilla and the mandible 0.7 and 0.3. So there are some changes. Are those changes clinically relevant? No difference in overjet, no difference in overbite, right? 5 years later, no differences. And 5 years later, no differences. So in other words, be careful with the mere changes, right? Because over long term, it may not matter. Or those 0.2, 0.3, 0.8, they get compensated by craniofacial growth and changes in there, and it may not be such a big problem. Another case. And now we have an interesting dilemma in this patient. Again, you see that the patient has a relatively concave profile, a degree of crowding that is not necessarily significant in the maxilla. The mandible, there is crowding, and then we still have a 7-3, the lower left deciduous canine, and an open bite tendency, right? And then you see there that the face is somehow starting to develop a long face. Now, this is the pan, and then interesting enough, we have here a patient that has a supernumerary. Now, the patient goes to the surgeon, and this patient comes back, and then you see here the lateral sac with the vertical grow and the open bite. But this patient comes back from the surgeon, and then the surgeon decided to actually extract the lower left permanent canine, the supernumerary, and the decidus. So, in other words, by extracting that lower left canine for surgical reasons, then I was forced to then, although that's not necessarily a bad thing to do, I was forced to extract 3 premolars to compensate, right? And so I was able to finish the case with a reasonable occlusion. There is a little bit of space distal to the upper lateral, left lateral, but the patient, and I discussed with the patient, well, I can center the midline if I were to use that space, and the space is going to show in the right. We'll have to probably build up or have a little bit of space either side. Patients that just told me, that's enough, I'm happy, get them off. I want my upper midline center with a facial midline. I don't necessarily care about the lower and upper midline center, which is a good conversation to have with the patient. But anyway, so 28 months of treatment, and then I showed this retention 3 years later, right? And again, like the other patient, now the fixed retainer is in place without gingival concerns. Upper arch is relatively stable. There's no clear rotation of teeth, but the growth of the mandible is not helping, because now you start getting a tendency for an anterior crossbite and an open bite, right? And should I treat the patient later? I offer retreatment for the patient, but the patient declined. And you see that the space, it's gone now. So, we are now in regards to the use of positioners compared to a mandibular fixed retainer. And then they did not identify significant differences in the maxilla anterior regularity, right? And remember that these patients were using thermoplastic in the upper arch or a positioner. No difference in the intercanine width after 1 year, but some after 2 years, and that difference, I didn't put that clearly, if you see, it's 0.8 millimeters, so less than a millimeter in the maxillar intercanine, and a reduction for the group that was using the positioner instead of a thermoplastic. And then no difference for the maxillary intermolar width, 1 and 2 years. No difference in the maxillary arch length, so no difference in the length, but somehow a little bit of a constriction at the canine level. We go now into the mandible, and again, the irregularity in the mandible was no different after 1 year, but after 2 years there was a difference, and the difference is a millimeter against the positioner compared to the use of the fixed retainer. So a positioner is used in some cases, but I guess one of the problems with the positioner, because it's flexible, is some degree of relapse is to be expected. And then you would ask you, it's not necessarily superclinical relevant. For the intercanine mandibular, intercanine width, no differences. No differences for the intermolar width. For the arch perimeter, no differences. Overjet, 1, 2 year follow-up, no differences between the methods, and no differences for the overbite. Maxillary irregularity, no differences. Mandibular irregularity, no differences. So, getting close to the end, start now to also talk about an area that I did not have the time to cover, but certainly it's an important consideration. And I will have to name here Christos Katsaros from the University of Bern in Switzerland as probably the person that has investigated this area a lot more in the world, which is the concept about the potential negative consequences of the fixed retainers, especially the lower ones. In other words, when we do actually put a fixed retainer, and then this fixed retainer, and without us knowing it, actually has some degree of twist in the retainer that we are not aware, and then we bond it. Eventually, the wire is going to try to recover its shape, and it's going to generate unwanted dental movements. These cases I show you, them are from an articles published. And you're going to see, especially in that middle one, look at what happened with that lower left canine, and in the right with the lower right canine, and then the fenestration and the histamine formed by fixed. So just a reminder to be careful with the fixed retainers. I've been lucky not seeing this degree of problems in my patients. But it's important to know, and I strongly suggest you to have a copy of this really well put together book by Christos Katsaros that goes about the stability, retention, relapse in orthodontics. Final point of completion from this Cochrane review is the use of a maxillary thermoplastic with mandibular IPR, not fixed, mandibular IPR and positioners versus positioners. We are not going to see here then the use of the difference there in irregularity. We are going to see no difference in the maxillary intercanine width, quite similar to the one before, the group operation before, but some differences after 2 years. That will be an equalization of 0.9 millimeters. I repeat, 0.9 millimeters, not a lot more. No differences at the level of the intermolar and maxillary arch length. When we go into the mandible, then although after 1 year there's no difference in the mandibular irregularity, there are differences after 2 years. No difference in going to the intercanine, there was no difference in intermolar. And then in regards to the perimeter, again, after a year, there's difference, but it disappears after 2 years, which is interesting, right? But we're talking about minus 0.5 millimeters that goes into the 0.1 after 1 year. So there's some settling and changes probably related to craniofacial growth. No difference in overjet, and no difference in overbite. No differences after 5 years in irregularity for the maxilla and for the mandible. So, some final thoughts. Maybe again going back to Game of Thrones.
Welcome, sir.
Right? The only true wisdom is knowing that you know nothing. How much do you really know or we know about this? I on purpose pick up a specific systematic review because I thought it did an interesting analysis of several variables. And as I reported earlier, this is a 5-year-old systematic review, and there's been a few RCTs published. I've been monitoring them, but in the overall picture, they don't necessarily change these conversation conclusions I had in this presentation, right? And then there's a time allocation about how many studies can I put in a presentation, right, before it actually loses the main point of the conversation. So we still are learning and doing RCTs and better RCTs as we move forward. I would like to then, near the end, before I go with the take-home messages, is pose some interesting philosophical questions for the group. Right? Is the success defined by the patient? In other words, a patient is fully satisfied even though we could quantify or qualify relapse. And remember the numbers I've been showing you are a millimeter or less, right? Maybe that's good enough, right? So success defined by patient. Is it success if there is no absolute no dental movements? What about minor relapse? And now again, think about the first paper I showed you and how over 40 years teeth are going to shift. And so is relapse a problem with the orthodontic treatment? Or is that minor relapse a simply reflection of adaptation of the teeth to the changes in occlusion as part of the craniofacial growth? Are we set the bar too high in perfection and lack of movement compared to accept that that is a fact of life, right? And then didn't really cover that in detail in this presentation, show you two cases, but the conversation about what about minor relapse, bite openings, and craniofacial growth. So, my take-home messages are, there is no irrefutable evidence that one specific retention approach is clearly clinically superior. So whatever you're doing probably is not wrong. It becomes more or less about what's important to you, right? Some clinically relevant tendencies were identified, and then we discussed that, yes, as no surprise, with the use of fixed retainers, your trait is you are likely going to get less dental movements, but you increase the chances of gingivitis, gingival bleeding, and increase of probability. These papers don't tell about the frequency of it, and if it's a 1 in 10 or 1 in 100, it changes the picture. And then the removal retainer then doesn't have those side effects, but is more likely to allow some movement. And in part of because the plastic's still a plastic and there's some wiggle room for the teeth to shift. And it seems that in that sense, then the thermoplastic provides a better stability than the Holy, but the Holy allows us better settling of posterior contact, so it depends on what you want in your case. In general terms, all this discussion is based on questionable certain evidence, right? And so it's a topic that is hot, controversial, and it will be, because we don't have clarity. What's important to notice is that I didn't talk about, because this paper did not, about differences in potential relapse based on the original malocclusion, right? We've been talking about an upper and a lower arch, but not necessarily the occlusion between them. And late mandibular growth in a patient that was perfectly finished, overjet and overbite, without a fixed retainer, we've all seen that either the bite goes into crossbite, or you get what's called the late mandibular crowding, which is the reflection of the nature about the continuous contact between the lower anterior teeth and the upper teeth, and then the fact that they will have to get crowded as the mandibular grows forward. So thermoplastic retainers present a slightly lower performance, right? Although the difference is clinically questionable. No differences were noted between fixed retainers, twist flex, bonding 3-3, or a thicker wire, seem to work similarly well. An increased tendency for gingival inflammation for the fixed retainer, I mentioned, Last two slides. Remove retainer type does not seem to matter in the big scheme of things. The thermoplastic retainers seem to have more stability than the Holy retainers. The difference is clinically questionable. Patients, and that's maybe important, I'm not aware how much you were considering what the patient thinks. Patients seem to prefer fixed or thermoplastic retainers over Holy opaque retainers. And in practice, I tend to use exactly the fixed and the thermoplastic in part because of this. Thermoplastic retainers seem to have more failures than Holy retainers when used over the long term. Modifications of thermoplastic use seem to be performed similarly to the standard 8 hours, and I think that's an important point to take home. It is clear that the patient doesn't need to use the removed retainers 24 hours a day. If they were to use it at least half a day or 8 hours a day, that would be the same result over the follow-up up to 2 years. And adjunctive procedures like IPR or positioners do not seem to generate a clear clinical advantage. Although with the IPR in that paper, Turkish good paper, it shows a similar stability with fixed retainer. So thank you all for staying up so late in Monday and Father's Day. And I am more than happy now to go on a conversation about the Q&A, right? And I just tried to actually generate some controversy so that we can have a healthy conversation to the fact that there is a topic that certainly doesn't have clarity. Thanks a lot.
Thank you very much, Dr. Carlos. It has been a very nice presentation, but as you have emphasized yourself, it's a very vast topic with a lot of controversies, and there is no single point on which most people are believe in. Now, the importance of retention cannot be emphasized more than the fact that many researchers or clinicians have offered to give half their fees if somebody can retain what they have achieved. So that shows how important the phase of retention is in orthodontics. So in the light of this, we thank you very much for spending your valuable time on this Sunday morning and being here and sharing your thoughts on this topic with our learned members. Having said that, some of our members have some questions, and could we start with Dr. Sandeep, who also already has a couple of questions lined up. So could we start with Dr. Sandeep? After that, kindly unmute yourself and you could discuss with Dr. Carlos directly, or your questions can be directed to Dr. Carlos directly, who I'm sure will be more than happy to answer. But having said that, don't hold him back for too long. This is a Sunday morning, and let him go back to his family to spend a good time on Father's Day with his family. Thank you.